who presented earlier on social communication, a program called the SAS. And now I'd like to introduce some other colleagues from Dublin who are going to present on a variety of very interesting research in CAMHS. Arranged, there's three speakers. There's Niamh Quinlivan, who's a speech and language therapy manager. She's going to talk about SLT diagnosis in previously undetected cases of speech and language difficulties for young people who attended an inpatient setting. And very interesting, 95% of those children who were assessed over a 4-month period last year were found to have difficulties with friendships, social communication, and difficulties expressing their emotions. And then our second presentation is from Marie Fahy, Speech and Language Therapy Manager, and Jennifer Brophy. And Jennifer Keogh, sorry. They're going to report on evidence for exploring language and communication needs in cases of self-harm. Their study explored the positive outcomes for a 14-year-old girl who had previously undiagnosed speech and language difficulties. And our last speaker then is Schaefer Doyle, who presents, she's a speech and language therapist as well. She presents a case for co-production between service users and professionals who work in CAMHS. This is an award-winning initiative where they provided easy-to-read information, a booklet, to demystify what CAMHS is for users, including vocabulary terms, picture material, and easy-to-access material. So very, very, very pertinent, and she's sharing that with other CAMHS professionals, and it's very, very helpful. So I would like to start now with Niamh's presentation. Thank you.
I'm the Speech and Language Therapy Manager in Indara CAMHS, which is a child and adolescent mental health service covering South Dublin, Kildare and West Buffalo healthcare area in the Republic of Ireland. I'm here today to present on a quality improvement initiative the Speech and Language Therapy Department undertook in Indara in 2020. I'm going to start by perhaps explaining a little bit about the service in which I work. As I mentioned, it's a child and adolescent mental health service. There are 8 community CAMHS clinics, and there are some specialist pathway services as well, such as our community eating disorder specialist service and our service for young people with intellectual disability and who also have co-occurring mental health issues. Within Indara, we also have a 22-bed inpatient unit, and it was within that part of the service that this quality improvement initiative was undertaken. So I'm going to begin now by sharing my slides. So the Indara CAMHS Approved Centre is a 22-bed CAMHS inpatient unit for young people under 18 years with severe and complex mental health disorders. We provide acute, emergency and specialist inpatient child and adolescent mental health service for young people presenting with a range of quite complex and severe mental health disorders such as anxiety, depression, psychosis, and eating disorders. There are 2 units within the approved centre with 11 beds in each unit. The first unit is for children aged from 11 to 12 up to approximately 14 or 15, and then the second 11-bed unit manages the care of young people who are age 15 up to age 17. I suppose the range of admission time varies, anything from between 2 weeks to several months. And for the purpose of this quality improvement initiative, the age range of the young people who were admitted to the approved centre during this time was between 12 and 17 years. So I'm just going to perhaps reflect a little bit now on the evidence for the role of speech and language therapists in CAMHS. I suppose research supports a long-standing association between children's communicative competence and their mental health. And there's a number of studies here which would further support that viewpoint. So, Cohen et al. In 2013 found there was a high incidence of communication difficulties in young people with mental health difficulties. Hollow et al. In 2014 looked at children with social, emotional, and mental needs, and they found that 81% of the group that they looked at had significant unidentified language deficits. And then the final study that's mentioned here is by Durkin and Conti Ramsden. It was carried out in 2010, and they found that loneliness and peer rejection in adolescents may contribute to adverse mental health outcomes for young people with compromised language skills. So I suppose it's important to bear all of this learning in mind as we continue now to talk about the Quality Improvement Initiative in Lindara. So just I suppose to talk a little bit about how the service is structured in the Approved Centre. Prior to the onset of the pandemic in 2019, we had one speech and language therapist working across the entire Approved Centre. So they were covering the 22 beds. Therefore, with this reduced capacity, young people were accessing speech and language therapy purely on an MDT referral only basis. So speech and language therapists were very much dependent on members of the team to identify young people who they felt may be presenting with communication difficulties, and it was these young people then that were seen for speech and language therapy assessment or intervention. I suppose as a result of that, approximately 40% of the admissions to the Approved Centre were seen for speech and language therapy input. I suppose with the onset then of the pandemic in March 2020, the Lindara management team agreed to operate a pod system within the Approved Centre to assist with infection control measures. So there was to be no crossover staff between the units. And because of this then, we were enabled to get a second therapist and base them in the second unit in the Approved Centre to assist with these infection control measures. This increased capacity allowed us to provide access to speech and language therapy for all of the admissions to the Approved Centre. And so we were able to develop and implement a communication screening programme across both units. And as I said, this resulted in all young people being seen by speech and language therapy. So this communication screening programme commenced in April 2020 and ran for 4 months until July 2020. During that time, there were 39 admissions to the Approved Centre, and all 39 were included in this screening communication programme. Okay, so move on. So maybe just first to start, just talk about a little bit around what the screening process involved. So clinical interviews were carried out with the young people, and these interviews asked the young people to reflect and talk about their own communication skills, their ability to process language, to understand what people say to them, and their ability to express their own thoughts and emotions using language, their social communication skills. So we asked them about things like how comfortable they felt meeting new people, how comfortable they felt speaking in groups versus speaking in one-to-one situations. And we also, I suppose, discussed what it was like for them to initiate conversation, to maintain conversations, to end them appropriately, to express emotion, to seek further information, and to provide further information when others requested this of them. We also asked them about their friendship skills. So we looked at their history of friendships, really, I suppose their ability to make friends and to, I suppose, more importantly, to maintain those friendships. So what we found, a lot of these young people were able to establish some connection or some relationship with peers, but the difficulty really was when a particular issue occurred and some conflict occurred in the relationship. They were unable to maintain those friendships. We also asked about their school experience. So we asked about their participation in school, their academic progress, and I suppose their social interaction as well in that setting. So similar to the young person's interview, we also spoke to the parents, and at the time this was carried out over the phone as we were unable to allow parents into the unit for individual sessions, again due to infection control measures at the onset of the pandemic. So we gathered a very detailed developmental history, looking at the speech and language development and also the social and emotional development, as well as the in-person academic progress. And so a lot of parents were very quick to identify that social communication was a difficulty for their young people, their children, and also, I suppose, the friendships. They were able to say, look, that a lot of these young people were quite isolated and wished that they had more friends, but for whatever reason were unable to make friends or to maintain relationships. So I suppose while they were acknowledging that there were social communication difficulties and that there were friendship difficulties, very few of the parents actually made the link between those two issues. So then the other piece that we looked at was the observation of the young person's participation in the Approved Centre Therapeutic Group Programme. So we run friendship skills, expressing emotions, groups, and assertive communication. So the young people were, I suppose, provided with the opportunity to attend these groups where many of these areas were discussed, and they reflected on their own experience of expressing emotion, making friends, communicating assertively with others, and they would have spoken openly about the difficulties they experienced in these areas, and I suppose more importantly the toll that took in terms of their mental health. So how many of them, had come to the point they were now teenagers, and they felt, what was the point really? They weren't good at expressing emotion, they weren't good at talking to new people, and they had pretty much decided that they weren't going to continue trying to do this. This had led to a lot of, I suppose, withdrawal and social isolation, leading to feelings of loneliness, which I suppose impacted on mood and also on the anxiety levels of the young people. And then for 50, I think it was 56% of the admissions it was, so that was 22 out of 39, were seen for formal language assessment. And this formal language assessment was the clinical evaluation of language fundamentals, the 5th edition. It wasn't appropriate to see all 39 for a formal language assessment. The decision making around who was seen for language assessment was influenced by the person's physical and mental health and the stage they were at in their recovery process. Out of the 22 that were seen for a language assessment, 13% presented with 13 out of the 22 presented with underlying language difficulties. So this is 59% of those assessed presented with language difficulties. And when I say language difficulties, I'm talking about I suppose some difficulties around understanding what people are saying to them, difficulties expressing their thoughts and emotions. And this also would have an impact on their social relationship as well as academic progress. So many of the young people, again, when we ask the questions, I suppose specifically around communication and the young person's experience of communication with their peers, they were very forthcoming in terms of sharing the experiences that they've had. And I think in a lot of cases, they were actually quite happy to have an opportunity to talk about these difficulties because they had been long-standing really, and I suppose had troubled the young person for some time. So one young person, this was put I suppose his own difficulties in his words. He said, when you can't explain why you're doing what you're doing, why you're behaving, how you're behaving, that's what is the problem. So he clearly had difficulties in expressing his own thoughts and emotions. Another young person referred to how it makes me feel nervous or sick when he needs to initiate conversations with others. And so again, what was particularly evident for many of the young people was that anxiety that they experienced around having to initiate conversation with people that they did not know very well. Another young person talked about, I don't want to bore my friends, so just speed up my speech and ramble. Someone else said, I don't know what to say, I just mumble because there's no point. And again, I suppose that's what I think that quote in particular really emphasises how many of these young people had started to opt out and to avoid social interaction because they just felt it wasn't working for them and they were really, I suppose, tired of trying. And then another young person told me I was cheeky when I said the wrong thing. I didn't know what they were talking about. So I think this is a good example of how somebody with a very subtle underlying communication difficulty or an unidentified communication difficulty may be misconstrued or misunderstood by other people. So the results then, looking at, I suppose, what we learned from this quality improvement initiative. The most common difficulties that were reported by parents and young people were social communication, were difficulties in relation to social communication, so particularly in relation to friendships and difficulty expressing emotions. So they were, I suppose, two themes that were very apparent in our interviews with parents and also the young people. 95% of those that were admitted to the Approved Centre over this time, so 37 I think out of 39, presented with communication difficulties. And that, I suppose, to be more specific about that, some presented with purely social communication difficulties, while others presented with social communication and language difficulties. 22 out of the 39 were seen perform a language assessment, I've mentioned that earlier on, and 59% of them presented with language difficulties. And I suppose, that led to further issues for them socially and academically. And I suppose the really concerning thing for us then, looking at these results, were that only 10% of the cases, so only 10% out of the 95% that have been identified as having some degree of communication difficulty, had contact with SLT in community CAMHS or in other services, so in disability services or primary care, prior to their admission to the Approved Centre. And I suppose many of these cases had attended CAMHS for quite some time, and I suppose had a lot of different interventions had been offered and tried with these young people, but unfortunately hadn't been successful. And I suppose, as we know in mental health, a lot of the interventions that we offer young people are delivered through the medium of language. And so for young people with communication difficulties, clearly this is going to create a barrier for them in accessing these interventions. So what were our learning outcomes? Well, I suppose in keeping with the research evidence, there's a high incidence of communication difficulties in young people admitted to Lindara CAMHS Approved Centre. As I said earlier on, the communication difficulties generally were not identified prior to admission, and the vast majority, 90%, had not ever been seen by a speech and language therapist, despite clearly having underlying communication difficulties. I suppose the other thing that became quite apparent as well was that, from the parents' perspective, there was limited or very little awareness of the direct impact of communication difficulties on the young person's mental health. And for us as a discipline and as a team working within the Child and Adolescent Mental Health Service, we feel and we've recommended that earlier SLT input and a full communication screening assessment in community CAMHS is indicated, particularly, I suppose, for these more severe and complex cases. It's really, really important that we outrule the presence of communication difficulty much earlier for these young people if we are to influence the ultimate therapy outcomes. So I suppose to conclude, the learning from this quality improvement initiative really, we looked at the communication screening program, and I suppose further to this quality improvement initiative, we were successful in securing the second speech and language therapy post in the approved centre. So we now have 2 speech and language therapists working in our approved centre full time, and that has obviously created additional capacity to enable us to implement this communication screening program on a permanent basis. The speech and language therapists working in the approved centre have increased their engagement with the parents as well to help support them and develop their understanding of communication difficulties, particularly when they're very subtle and not very apparent. We do a lot of work with parents around understanding the impact of communication on mental health, and we also support them by informing them about communication strategies that can be used in the home in order to support the young person's communication, particularly at times of distress. So further to the development and the implementation of the SLT therapeutic group program in Lindara Approved Centre, this has now been rolled out to the community CAMHS services. So we now have a number of therapeutic group interventions across our service that target assertive communication, friendship skills, and communicating emotions, which, as I said earlier, were the 3 main areas that were identified as being problematic for young people over the course of this quality improvement initiative. And then just to finish off, I suppose the parent group runs in the approved centre, and we now have also extended that to be available to parents in community CAMHS. We've shared the learning. So the learning from this quality improvement initiative has not only been shared within our own discipline and our own team, we've also shared this with our colleagues across Lindara CAMHS. And I suppose what we found over the past year since we've done this work is that a lot of these more complex cases are now being referred for speech and language therapy input much sooner than they were prior to this piece of work being completed. And we have also shared this work nationally with the other approved centres. As part of our new service staff induction, this piece of work is also included, so that the learning is also shared with new staff when they join the service. And as a discipline, speech and language therapists, we have shared this learning with our wider profession and colleagues, in CAMHS and in primary care and disability services. This quality improvement initiative has been presented at our professional body conference in Ireland and in the UK this year, in an attempt to contribute further to the evidence base around the role of speech and language therapists in mental health. So that brings me to the end of my presentation. I'd just like to say thank you so much for the opportunity to present today. And my email details should be available if anyone wants to contact me with any questions. Thank you.
Thank you, Niamh, for an excellent presentation. We might wait until the end of the presentations for questions, unless anyone has a burning question. That's okay. And we move on to Marie Fahy and Jennifer Keogh are going to talk now about a case study on a 14-year-old with self-harm and exploring her communication skills. Thank you.
Good afternoon. My name is Marie Fahy, Speech and Language Therapy Manager at Dublin North City and County CAMHS. And I'm here this afternoon to speak to you about supporting communication in a young person presenting with self-harm and language disorder in CAMHS. My colleague Jennifer Keogh, Senior Speech and Language Therapist, will present this case report, and I will speak briefly about a literature review on speech and language therapy and mental health, and specifically self-harm. Jennifer and I work in Dublin North City and County CAMHS, and we provide specialist mental health services to an under 18s population of 141,796 young people. And Dublin North City and County Mental Health Services comprises of 8 CAMHS teams, 1 day hospital, and 1 inpatient unit with 12 beds. Myself and Jennifer are integrated on 2 different CAMHS teams. And just the next slide. Going on to the next slide. So to introduce then, why are we looking at the SLT role in self-harm right now? Well, there's very little literature on the role of SLT in self-harm, and myself and Jennifer looked at some of the research. So I will take you through a study by Hetrick et al., and we will link our role in SLT to that particular study. And then Jennifer will go on to talk about the case report. Okay, so what is the role of speech and language therapy in CAMHS? Well, we provide services to young people to support effective communication. They may be presenting with speech, language, and communication needs, and we're specialists in that area. So we would identify and support those young people presenting in CAMHS. We would provide support within the context of mental health interventions underpinned by the recovery model, and our ultimate aim is to maximize the young person's communication and participation in communities. It's a clearly defined role. We're integrated in CAMHS teams, locally and nationally, and we can ensure access for young people to talking therapies, as we notice in our work that a lot of young people with speech, language, and communication needs find it difficult to access psychological interventions. So as I said before, there's a lack of specific literature on the links between language and communication needs and self-harm. And as we know, language and communication needs are a significant risk factor for developing later mental health difficulties. And many mental health interventions, we place a heavy burden on a young person's ability to understand and use language. Young people who present in mental health services are expected to report concerns, analyze their behavior, reflect on their behavior, and understand consequences. And oftentimes, language assessments, which would be very helpful, are not routinely completed before such therapies are undertaken. Or also mental health assessments can be, I suppose, place a heavy load on their language abilities. So looking then at mental health disorders and language, children with mental health disorders are about 5 times more likely to have speech and language problems than those without. And specifically, adolescents referred to mental health services are 3 times more likely than peers to have higher order language disorders. So what that means is problem solving with language, reflecting, and those skills I mentioned previously. You need quite good abstract thinking skills and inferencing to be able to access support in mental health services. And with any kind of language disorder or delay, that will impact your ability to be able to undertake these interventions. So what Jennifer has done is, in her work, she has linked this particular study, Hetrick et al., a Melbourne-based study, and looked at how SLT can support communication to address the triggers or the risks for young people. So this particular study by Hetrick aimed to address gaps in the literature in relation to triggers for self-harm and what young people find useful. 7 young people with lived experience of self-harm were interviewed, and afterwards the data was analysed for themes. So I'll just go through some of the themes then, and we will look at how SLT can assist effective communication to address each of these themes. Just to note, this was not done in the study. This is something we're doing now to link our role as SLTs to this previous study, a Melbourne-based study. So the first theme, distressing emotions. We noted that SLT have a significant role in CAMHS in improving emotional literacy and regulation skills. The second theme, sense of isolation. Oftentimes we're supporting social engagement and targeting social anxiety. A third theme, relationship difficulties. Again, we're supporting the development of effective communication skills. School and work difficulties. So the SLT role is to provide assessment and liaison to assist young people in understanding academic vocabulary. And another key theme, exposure to self-harm. So again, we can help the young person manage social media use, manage those interactions with peers. And finally, social comparison. We can help young people tell and own their story. At this point, I'll hand over to my colleague, Jennifer Kyo, who will take you through her case presentation.
Hello there. Let me take you through a case study. So Em is a 14-year-old girl referred to CAMHS due to frequent thoughts of self-harm and suicidal ideation. She is multilingual and has been exposed to Russian, Romanian, and English. She has never attended a speech and language therapist before, and no previous language difficulties have been identified. At intake, it was noted that she struggled to articulate multisyllabic words, and a formal language assessment was organised. In the interest of time, I won't go into too much detail with the background history, but here are some of the important factors in her case. So she was born prematurely. Her dad had an affair and left the family home, and the family subsequently became homeless. This all happened at a significant time in her development. Em is also struggling academically and reported she can understand Russian and Romanian, but she is not confident in speaking them. She says that her words come out muddled up sometimes. She's difficulty spelling, and she finds it hard to take things down from the board. A standardized assessment of language was administered, and language disorder was identified. So Em also described her father's history of low mood and difficulty learning English, despite living and working here in Ireland for over 14 years, which makes us think that her father may have language difficulties in both Romanian and English as well. So she started self-harming soon after starting secondary school. She had not been in the feeder primary school, and she had no friends. She disclosed her self-harm to a classmate who then relayed this information to the whole class via text, which was very upsetting for her. She also struggled to communicate with Dad, and that relationship was a great source of stress for her. And she was struggling academically due to her language disorder, and she was avoiding school. She was an open and honest young person. She was extremely cooperative throughout the whole assessment, and she also had a close relationship to her mum. She had learned to use some distraction techniques when she had the urge to self-harm. If we look back at the Hetrick et al. Paper, we see that she had a number of the triggers present in her life. So the family were homeless for nearly 2 years, and she'd recently moved to a new area to start this new secondary school with no friends, and then she started to self-harm. She shared her self-harm behaviour with a different friend who subsequently started self-harming, and this made her feel very guilty, and she wanted to self-harm even more. She was struggling academically due to her underlying language difficulties. This was causing her to avoid school, and her relationship with her dad was tense and a source of distress for her. Her language difficulties make it hard for her to describe her inner experiences and her emotions, and also the turmoil of her dad leaving the family, being homeless, continued tense relationship with dad, and her guilt at causing her mum pain have all led to her experiencing distressing emotions and using self-harm as a way to cope with this. So here we see a copy of her results from the Clinical Evaluation of Language Fundamentals 5, or the SELF-5 Standardized Assessment, and a language disorder profile was identified. So she had significant difficulties with auditory memory, understanding time, sequencing words, constructing sentences, and articulating multisyllabic words. Consequently, these would compromise her ability to follow classroom instructions, remember information, engage with subjects with highly technical language like technical graphics and maths, and also she would find it difficult to express distressing emotions and concerns. She did tell us that she had difficulty writing essays and reading, which also caused a lot of distress for her and avoidance. But overall, her understanding of language was much better than her ability to express herself, and that mismatch in itself was upsetting and frustrating for her. As speech and language therapists, we look at a young person's receptive and expressive language. I find the communication chain shown on this slide to be really useful at pinpointing areas of difficulty. So receptively, M has significant difficulties with auditory memory. This is making it difficult for her to follow classroom instructions and remember information. Understanding concept words such as time, sequencing, before, after, they're all pretty difficult for her, making maths very hard for her and certain subjects in school very, very difficult. Expressively, she described herself as muddling up her sentences when she talks. This will impact her ability to put her thoughts in order, to say coherent sentences, and to write essays. She finds multisyllabic words difficult to pronounce, and she's also struggling with reading and writing, and she needs an assessment to explore dyslexia. Her communication difficulties are having an impact on her mental health. A discussion with her head teacher revealed that she had missed a lot of school. She didn't attend the end of term or the end of year exams, and they had very little information about how she was engaging with the curriculum. Her teachers had missed this or had not identified her language difficulties due to her lack of attendance and her mild-mannered behaviour in school. The teachers also assumed that some of her issues were related to English as a second language, whereas M would say English is actually her strongest language. So school is a major cause of distress for her. She also got into trouble at Halloween with the police as her and her friends were created a bonfire. It is possible that she didn't fully understand what her friends' intentions were, but also when the police caught them, her friends were able to engage, talk to the police, and they weren't arrested, they were just brought home, whereas she couldn't. She couldn't interact with them, she couldn't answer their questions, and she ended up being arrested, and which was very stressful for her and her family. And it is likely with added stress that people with language disorder will find it harder to understand questions and to express themselves. She had the urge to self-harm after this, and as she felt very guilty for causing her mother pain. Also, she's continuing to struggle with her relationship with her dad. She finds it difficult to understand his point of view. She cannot communicate with him effectively, and this relationship is just a major source of distress for her and a reason for her self-harm and her thoughts of suicide. So if she was able to communicate with him better, would it ease her distress? We hope so. So a speech and language therapy plan was put in place to support her communication skills in CAMHS and in school. So our head teacher created an individualised educational plan, an IEP, which considered her underlying language difficulties, and then shared this with her teachers and family. She received individual educational support with an appointed teacher to support her academic work. And myself and the teachers recommended an educational assessment with an educational psychologist to explore dyslexia. The communication chain was used to share information with the school and with the CAMHS professional staff here. And I provided the teachers with resources and advice in order to support her communication skills to access the curriculum. The consultant child and adolescent psychiatrist adapted their review sessions accordingly. So they used short, simple sentences, and they gave her just that bit extra time to formulate her answers, which made the sessions more accessible. She was given individual speech and language therapy sessions in addition to her therapeutic sessions with her psychiatrist. And these sessions centered around increasing her knowledge and understanding of friendships and relationships. Theory of mind was explored to help her understand others' perspectives, and she was also provided with several strategies and visual aids to help her remember and learn new words, and curriculum-based vocabulary was targeted. So following her speech and language therapy, she reported that she was trying to understand her father's point of view. Although she continued to refuse to go to school once or twice, she did attend the end of year exams. She changed her perspective on how she viewed friendships, and she put more energy into making new friends rather than focusing on just one relationship intensively. And her knowledge of curriculum-based vocabulary improved. So following the identification and treatment of her language disorder, significant improvements were made in her ability to communicate and engage with her peers, her family, her teachers, and her mental health psychiatrist. Progress was generalised at school by sharing communication strategies with teachers and parents, and she was supported to express her distressing thoughts and feelings in her mental health reviews. So she improved her pro-social behaviours. She worked on being considerate of other people's feelings, which will hopefully reduce the risk of persistent emotional difficulties and peer relationship difficulties in the future. More in-depth research is required, including a larger sample of young people, as this is just a single case study. This case report highlights the importance of increasing awareness that communication difficulties act as a barrier to both diagnosis and access to mental health interventions and academic progress. which all tend to be verbally delivered. Her treatment plan took into account diagnosis of language disorder and adapted sessions accordingly, which resulted in improved mental health outcomes. A limitation of this single case report is that mental health outcome measures weren't administered pre and post intervention, which would have provided useful measurements of recovery. The impact of homelessness on M's communication and mental health were a significant risk factor, which requires more in-depth examination in a larger scale investigation to support young people who experience adversity. So the clinical implications really are that increasing awareness that communication difficulties exist in people with mental health disorders, and these difficulties can be a barrier to diagnosis and access to verbally delivered mental health interventions. So overall, our results provide new evidence for the efficacy of adapting self-harm intervention and exploring underlying language and communication needs in community CAMHS. Collaboration between school, home, and CAMHS enhanced generalization of skills, and incorporation of speech and language therapy has the potential to enhance overall mental health outcomes for young people who self-harm. And if we're here for any questions you may have.
Thank you very much, Jennifer, and indeed Marie. That was a very interesting presentation. A lot of parallels with Niamh's earlier presentation, and now we'll have Shafra Doyle, who's going to talk about accessible booklet initiative. Thank you.
Hello everybody, my name is Shafra Doyle and I am a speech and language therapist from Dublin, and I'm absolutely delighted to be here today to present a project that we co-produced as speech and language therapists in CAMHS in North Dublin. So thank you so much for coming to watch the presentations, and I hope you've enjoyed what you've seen so far. So like I said, I'm a speech language therapist from Dublin, and I've worked in the North Dublin CAMHS team for 2.5 years. So I've learned a lot about CAMHS in my time there, and worked with lots of different team members, and absolutely love mental health and love language as a speech and language therapist. So that's what I'll be presenting on today. CAMHS Made Simple is a little booklet that we made. And it's a booklet that breaks down language barriers for young people attending a child and adolescent mental health service in Ireland. So that's the title of my presentation today. And this is Symposia oral session number 42. The communication needs in CAMHS, the missing piece. So this is one of our missing pieces. Very good. So I'll just get straight into it. Sorry now. Very good. So what is CAMHS Made Simple? So basically it is a little booklet that we made, and it's about 14 pages long, and the crux of it is that it has easy to understand language, and it explains what CAMHS is to service users and to parents. Very easy to understand language so that they know what to expect when they're referred. So some of the things that's included in the booklet is all the different professionals that a young person would meet. So a speech and language therapist, psychiatrist, occupational therapist, nurse, administrator, the whole team. It explains the role of each team member on the CAMHS team. The booklet also goes through the pathway through CAMHS. So when you're referred, what happens after you're referred, that you'll be seen for an initial assessment, and then it'll be deemed whether it's deemed appropriate or not that this is the service for you, and just the various pathway through the service, and finally to discharge. The booklet also includes a list of words. So you'll see in the top right hand corner of the slide there, we've got a list of words that you would hear in CAMHS that young people with or without language difficulties might never have heard these words before, might not know what they mean. And we as health professionals tend to use a lot of jargon sometimes without being mindful of the fact that young people just don't have the same level of vocabulary that we have, or just may not have been exposed to that vocabulary before. So like words like diagnosis. So you can see here it says this is a medical word that describes your mental health difficulties or illnesses. An example is depression. And some other words there like discharge, goals, insight, what moderate to severe mental health difficulty would mean, what recovery means, and referral and review. And it's just got a list of words that young people might hear, so that when they come to CAMHS and they hear these words, hopefully they'll have read them first in the booklet and will have an idea about what they mean. Sorry, now I'm just going to time myself just in case I go over or under time. And yeah, so the whole booklet just describes the experience of CAMHS. It's got the numbers of all the Dublin North clinics, and you'll see in the bottom right-hand corner, there's a list of various links and supports that young people, when they open the booklet, like Jigsaw and Peter House, which are mental health services in Ireland that they could go to for extra support or for support before they come to CAMHS. And you'll see in the top right-hand corner that picture there, that's artwork that we've included in the booklet that is created by young people, some who were attending this service and other artwork from Mental Health Ireland. So they did a calendar competition, and lots of young people entered drawings that they had done or photographs they had taken that depicted mental health. So they are in the booklet as well. So it's 14 pages long, and it's all really simple language. And the purpose of it is that we would give it to young people, maybe at referral. So we've distributed it to GPs and various other referral agents, so that when they refer the child to CAMHS, they can be handed this booklet that explains exactly what it is. Because when you're in distress and you're told you need to attend a moderate to severe mental health service, it's all very overwhelming. You might be told what CAMHS means, or maybe you haven't been told what CAMHS means. Sometimes we just say you're going to CAMHS, and they don't know that maybe it stands for Child and Adolescent Mental Health Service and who they might meet and what the process is. So it just expels all that fear and just really explains what they can expect from the service. So that's kind of generally what the booklet is. So I'm going to talk through how we developed it, like the method that we went through, the results, so kind of how we've gotten on with the booklet, and then just some discussion points afterwards. So the rationale for the booklet, a booklet about CAMHS. Why bother? This took a long time to develop, and there's lots of reasons why. And the first and the main one would be that a large percentage of young people attending CAMHS have language needs. And language needs are oftentimes overlooked or undiagnosed. And it can be a very hidden difficulty that young people have. So if I just show you here that on the left there, 45% of young people referred to mental health services have higher order language difficulties. So higher order language would be kind of like inferencing, problem solving, understanding abstract language. So 45% of young people referred to mental health services have difficulties with that. And that's from a study by Cohen, Fernia and Imbolter. So for this was they did a study with 144 clinic referred young people and 186 comparison young people, all aged between 12 and 18. And they administered a variety of standardized assessments. And they found that those with mental health difficulties scored significantly lower for higher order language. And this included working memory and reading as well. So just something to be very mindful that our young people who are attending the service might be okay at conversing maybe in general, but some of that higher level language can be quite often much lower than the population or their peers. And similarly then, 81% of children accessing support for emotional and behavioural disorders have language difficulties. And that's a huge percentage. And that study was by Holloway and Oliver. So they did a random effects meta-analysis across 22 studies, and they had 1,171 children aged between 5 and 13. And all of these children were formally identified as having emotional or behavioural disorder, and they did not have a history of developmental, neurological, or language disorder. And their results found that 81% had language difficulties or language below the average range, which is a huge percentage. So that is why speech therapists are in CAMHS clinics in Ireland, and I know it's not the case around the world, but the language needs in this client group is quite significant. And this is language, this is oral language, but also communication, pragmatic communication too. So another rationale for the booklet is that young people may not know what CAMHS means at referral from GP. So like I said earlier, the GP says you're going to CAMHS, and young people don't know exactly what it means or what to expect. So I think it was an important reason why we decided to make the booklet, and to reduce anxiety about attending CAMHS by outlining what can be expected. And I think we can all agree that when you're going to a new service or you're doing something new, that when you have an idea of what exactly it might entail, it definitely reduces anxiety and be much more willing to attend. And then the final rationale for the booklet is it's not just for young people, but it's also for parents and carers who are probably equally as distressed as the child. The child has a moderate to severe mental health difficulty, needs to attend a service. They probably might not know what CAMHS is either, or how CAMHS can help their child, what it does. Do they see a doctor? Do they see a team? How long are they going to be seen for? So the booklet can also explain to parents and carers how CAMHS can help their child. So that's our main reason for creating. Okay, so the method. So just going to go through how we designed and delivered the booklet. So this presentation might not be like a lot of other ones at this conference. This is more about, this isn't necessarily a study that we did, but more how we developed this booklet, so that anyone watching could also maybe think about designing their own booklet for their own service and really see the benefit of why we need to do these things, and why we need to create language and literacy accessible information for young people attending mental health services. So I'm going to discuss the method in kind of 3 parts: define, design and deliver. And these are from the People's Needs Defining Change framework from the HSE, which is the Irish Health Service. So this is a change guide that helps us to implement new change initiatives in a structured way. So first we have to define the booklet. So identify the need for a booklet about CAMHS. We didn't pull it out of thin air, the idea for the booklet. It was discussed at a service user representative forum, where there was parent representatives and service user representatives, and this need for a booklet or some sort of information about CAMHS was brought up. And the current situation was that a lot of young people don't understand what CAMHS is and how it can help. That was definitely my experience with young people when I saw them for initial assessment and maybe asking, do you know why you're here? The response was often, I don't know why I'm here or what CAMHS is. So that was the current situation. We then had to design a plan for the project. We had to plan it out. Like I said, this took a very long time from the initial idea to publication. As part of this definition process as well, we had to make sure that the project aligned with Connecting for Life, which is a suicide prevention action plan for North Dublin, and the CAMHS operational guidelines. So we made sure that it was strategically aligned to national and local policies. So then the design of the booklet, and I'm going to talk a little bit more about co-production in the next 2 slides. So this booklet is co-designed. We didn't just make it by ourselves. We could have easily sat down as speech and language therapists and written this booklet and had it finished within a couple of days or a couple of weeks if we really wanted to. Instead, this took kind of a couple of years because of co-production. So we co-designed the booklet with young people and with CAMHS colleagues, and with all of our SLT team in North Dublin as well. So with young people, I'll explain the young people piece later on. Yes, so we got support from the National Adult Literacy Agency. So I'll talk a little bit about that. So that's the literacy agency in Ireland that makes sure that all written information is easy to read for anyone who might have literacy difficulties. So it was extremely important for us that we had their support and that we got their plain English stamp on our booklet, which means that the booklet is approved as plain English and it meets international plain English guidelines. So that means that anyone could really pick up the booklet and that the language is easy to follow, and it's easy to understand, and that the vocabulary isn't complex or anything like that. And that was a lot of back and fro between us and NALA, that's their name. A lot of back and fro about how to make the booklet as easy to understand as possible, which involved like very little images to avoid distracting the eye. There had to be a certain spacing and font, and different headings on different pages, and it just made sure that it was quite easy to understand. So that was really important that we got that stamp. To involve young people, we had a focus group with young people who were attending a mental health day hospital and inpatient unit. So we went and we brought booklets and colours, and we let them sit together and talk about the booklet, read through it, scratch things out, add bits in, whatever they wanted to do, and they provided great feedback about the booklet and any changes that we could kind of make. So it was really important that we got their support as well. We gathered artwork from young people, service users, as well as Mental Health Ireland. And the image on the front of the booklet is an image that's in one of the clinics in North Dublin, in Swords. And young people created this tree, this positive tree. So that's on the front of the booklet. So I think it's important that young people can see their artwork on the booklet. Throughout this whole process, we consulted with sponsors and stakeholders. There was lots of meetings with managers, getting drafts sent everywhere and come back to combine everyone's opinions. And we finally ended up with a really collaborative booklet that everyone had an input in, and that all of the CAMHS professionals could write into. So the section that explains what a psychologist is, the psychologists came together and wrote the piece for that. Similarly with administration, occupational therapy, psychiatry, they all came together and they wrote their own blurb about what they do in CAMHS, so that we as speech therapists weren't writing what they do, they were writing it themselves, which is very important. And then finally, once the booklet was designed and printed, we had to distribute it to all of the clinics in North Dublin. So the North Dublin CAMHS service is one of the biggest, or I think it is the biggest in Ireland. So this booklet now goes to every person that's offered an initial assessment. The booklet is included in their initial appointment letter. So at least they can read about the service before they come to us. It's been distributed to other agencies and general practitioners, GPs, and we've sent it to disability services, primary care services, international colleagues, anyone that we could send it to, we've sent it to. And we've got thousands of copies of it that have gone everywhere. So we're really trying to spread the word about CAMHS and CAMHS Made Simple, and making sure that language is accessible and that everyone knows what CAMHS is, and just to demystify CAMHS. The plan is to roll it out nationally, so we have sent it to lots of CAMHS teams around the country, and the hope is that these CAMHS teams can adapt the booklet for their own service. So as it stands, it's quite specific to North Dublin. It has the North Dublin numbers, and some North Dublin services that young people can contact. But the plan is that it will be adapted across the country for each service's contact details and things like that. And the plan is to assess effectiveness. So we have created little feedback cards, lovely colourful feedback cards for service users and for stakeholders and for colleagues. So we want feedback from everybody who is involved in the creation of it to see how effective it is, what changes people would like, what maybe to take away, and then to maintain that change over time. That's the method. Actually won't go through this. I'll move on to this here. So this is co-production. This is what I mentioned earlier. This was this whole piece of including everybody in the creation of this booklet. So co-production is an equal and reciprocal partnership where everyone's experience, knowledge and skills are used to create better outcomes. So I'll just tell you a little bit more about co-production. You can see the ladder there. To work up to co-production at the very bottom, you've got no engagement, information sharing, you're working your way up to education, consultation, participation, and then finally at the very top is co-production, which is the pinnacle. So through co-production, service users, family members and service providers can become active participants and equal partners at all levels within service design and delivery, at an organisational level, at an individual level. Sorry. At an individual level, co-production occurs in the development of care and recovery plans, for example, and at an organisational or strategic level, co-production is beneficial in the design and delivery and evaluation of services by ensuring that service users and family members are involved at all levels. This includes management team level, governing committees, service evaluation groups. So that's a little bit more now. So let's go through results. So by the end of the whole process, we co-produced a booklet that explains to service users and their parents and carers what to expect through their journey with CAMHS in jargon-free language. The booklet is strategically aligned with national and regional and local policies. It's included in all initial appointment letters in North Dublin CAMHS. It's been widely shared across sectors, including GPs, primary care, disability services, and so on. And it's received very positive feedback from a variety of stakeholders, and it's gained widespread support. So our community network manager said it was a lovely resource and that they will use it to understand CAMHS better. So it doesn't only help young people understand CAMHS, but it's been helping the wider health professionals understand CAMHS as well. Our clinical director said it was a great initiative with many inputs. The general manager said it was the information reaches many stakeholders. The service user in our focus group said that it would make them less worried about attending CAMHS. And someone had also said that they wished they had been given it themselves when referred to CAMHS. The quality surveyor from the UK, Dr. Saeed Nazir, said it was a very important document, inclusive communication about CAMHS, and he thought it was a brilliant project that we had undertaken for the CAMHS service in North Dublin. So why is language ability important for mental health? So I'm kind of moving on now to just some discussion points. So I've discussed the results. So why is language ability important? So I've said these 2 points earlier on, that 81% of children accessing support for emotional and behavioural disorders have language difficulties, and that 45% of young people referred to mental health services have higher order language difficulties. This is, and then we have many mental health treatments are delivered verbally. Language difficulties hinders access to these treatments. So bearing in mind the first 2 points about how prevalent language difficulties are in our young people in CAMHS, and if you think to all the treatments that we do, like CBT, which is very language heavy, you need to have good language skills to be able to engage in that treatment, as well as many of the talking therapies. If you think about how you think back on your experiences, how you explain yourself, even how you understand your emotions and describe your emotions is all very language heavy. So if you have language difficulties, like many of our young people in CAMHS do, that would make accessing these treatments extremely difficult. Poor pragmatic language at age 9 is associated with psychotic experiences and depression in adolescents. So that was a study done by Sullivan. And they had assessed young people aged between 12 and 18. And they had 7,659 participants. And poor pragmatic language at 9 years was associated with psychotic experiences. And then we also have an estimated 60% of young people in the youth justice system have communication needs. And that was more of a smaller study with just 58 participants. And a variety of standardized assessments were done with young people in a youth justice system, and it was found that 60% had communication needs, and there is a little bit of overlap with some people in CAMHS and these young people, young offenders, and it's high prevalence of language difficulties there too. Social communication difficulties can make young people more vulnerable to exploitation as they struggle to read and interpret the intentions of others. So that's why language is important. Oh, one more, sorry. Adolescents with developmental language disorder are more likely to have symptoms of depression and anxiety than their peers. So developmental language disorder is a very common language disorder. It's 2 in every classroom have a developmental language disorder, and they are more likely to experience symptoms of depression and anxiety than their peers. So we may see a lot of this cohort in CAMHS as well. So speech and language therapists in mental health services. I'm slightly running out of time, so I might just zoom through some of this. Speech and language therapists can work with a variety of client groups, including ADHD, liber self-harm, selective mutism, depression, psychosis, eating disorders, social and relation problems, and social anxiety. And I know that in CAMHS I've worked with every single type of client group, and we were really able to help them with their communication skills. So SLTs provide a unique role in the assessment, diagnosis and management of communication needs for young people attending mental health services. And SLTs can optimize communication for service users in all contexts, and also encourage team members to adapt their language and to consider the language and literacy levels of service users, which I'm hoping I'm doing that right now, is encourage everyone listening to adapt their language to service users. So in summary, we co-produced a booklet about CAMHS. We discussed how language needs are high in young people with mental health difficulties, and that providing language accessible information about services has the potential to build trust and decrease anxiety about attending the service, and that using co-production for service improvement initiatives can support an equal partnership between service users and mental health staff. And thank you to everybody here. And I'm just out of time. And this is my email here. And Marie Fahy, who was a huge person, a part of this project, and she led out the project, and that's her contact information there. And that's a picture of us. And the top picture is us presenting this project at a Health Service Excellence Award in Ireland. And the project was nominated as an exemplary project. So thank you all so much for listening. Please do reach out to my email or Marie's email, and I'm happy to take any questions that you have. Thank you.
Thank you, Shifra, and indeed to Marie and Niamh and Jennifer for an excellent presentation. You certainly filled in the missing piece for everyone about communication and the awareness of communication, the importance of detecting communication needs, and also bringing clarity about the meaning of coming to CAMHS, and about the language that we use. The words may not resonate with a lot of young people and indeed their parents, so all very valuable contributions. So if there's any questions, our speakers would be happy to take questions from the floor or otherwise or amongst each other, there might be questions. I certainly would like to receive some of the resources. One question I did have, if there isn't anyone else jumping in, was I don't know where I've written it now. I've written so much. Oh yes, for Niamh, I was wondering about the measures that you use. Could you recommend a screening tool? Like, I know you use the Self-5, but yeah, I think I might have asked you this already.
You did, and I realised as we were talking about it, I didn't get back to you about it.
Right.
We used, I suppose we developed a prompt sheet, Ger, and it was really to support the newer member of staff that had joined our team round about that time. We also drew from some of the talk about resource materials that were available within the department as well, and we used, I suppose, just the qualitative information and that we yielded from that to guide us then in meeting with the parents and conducting interviews with them. I think what we found was, if we introduced a topic or if we mentioned a particular area, we didn't have to probe very hard. The young people just flowed. They were very, very happy to tell us about the lifelong difficulties they had encountered. And I suppose, unfortunately for them, it had just never come up, or people hadn't connected the dots. Like, they would have said they were very quiet, or they tended to play by themselves, didn't have a huge group of friends, but didn't make the connection between that and the deterioration in the mental health when they hit adolescence. So I'd be very happy to share the prompt sheet and the actual questionnaires we use from the Talk About program. I'm sure you're familiar with that one. But as I said, I suppose we didn't have to probe too deeply. It came quite easily from the young people, and then we just looked at it for the themes that emerged, and certainly the themes that emerged for us were, the friendship and going into groups where you don't know people and trying to initiate conversation with people you don't know, anticipating, what would they be interested in? How could I engage them? Seem to be the common areas of difficulty.
Brilliant. Thank you. I'm just wondering if there's any other questions.
Sorry, just to finish off on that, just to say, since we did the screening, I suppose we have an additional therapist now in the unit, and we started using the CAMHS assessment. I don't know if you're familiar with that.
No.
So I'll send you on the details about that as well, Ger. It's a really, it's proving actually quite useful for the kids we're seeing, not only in the approved centre but right across the community CAMHS as well, where it consists of video clips. So you play video clips and you ask the young people to infer what's happening, and it breaks down, it looks at social communication in a number of different areas, and higher level language like inferencing, social communication skills such as, non-verbal communication, and the young person's awareness and their ability to use these skills themselves to support their communication. And I suppose what we're finding is, for those very, very, very subtle kids, it's actually been quite useful, really, to get a kind of a sense of where the breakdown is happening for them.
And do they all agree to participate in the assessment? Some young people might say, my speech and language skills are fine.
Yeah. And I think, I suppose in the approved centre, it's different because, unfortunately, a lot of them could be quite bored at times. So, they almost welcome the newness of meeting somebody else. And, I suppose we have a lot of young people as well that like structure and predictability. And I suppose there's nothing as structured or as predictable other than a formal language assessment. Let's do this task and we're going to do this other task and it's going to follow suit. So they do. And I suppose the other thing as well, just to say that because as speech and language therapists, we're talking about the communication piece and the difficulties they've experienced. I suppose what we found is that they're more likely to engage with us than perhaps psychology or dietetics in particular in the approved centre, where there's a number of eating disorder beds, and young people are less I think they kind of enjoy the distraction of talking about something different and something that is obviously of particular concern to them.
Fantastic. Are there any other questions from the audience or from our online participants? Just keep an eye on the time as well.
Sorry, can I just ask, Niamh, the parent information sessions that you mentioned, they sound really interesting. I think certainly in community CAMHS, it could be something that we could look at for, let's say, all of the adolescents that we know have language difficulties. It would be great to get all their parents together, even if it was an online kind of workshop. Or is it like information sessions or a workshop or a training or?
So it's something that we started. We've taken a lot of students this year, and we took advantage of the fact that we had that extra resource within the department, and we got them to put some presentations together for us. And it's really a kind of like a psycho-ed group for parents, looking at that link between communication, very similar to what we've all presented on now, that link between good communication and positive mental health, and you know, I suppose, you know, I suppose the close relationship between anxiety and communication difficulties. And so we trialed it in community CAMHS, and it's been received very well. And I think it also kind of came up for us because, you know, it's a discussion as therapists we all have with all of the families that we work with, you know, and you put so much time into that psycho-ed piece with the parents in the session that we wondered, would it be something, if we, especially with telehealth, we've used so much of it in the last year, would it be worthwhile putting a group together? And I know that Rosina and Emer, the therapists in the Approved Centre, ran one earlier this year, and it was really, really, really well received. I wonder, maybe perhaps the timing might have something to do with that, because it was during lockdown and parents weren't able to come in and engage like they usually would. So they were very grateful for that input. But it's very much about, you know, how to communicate with your child when your child is distressed. And like a lot, as I said, only 10% of the kids that we identified as having communication difficulties had ever attended speech and language therapy. And these are files that are like that thick, that have seen everybody, but were deemed kind of too unwell for the speech and language therapist to see them. You know, we'll wait till they improve, and then you can see them and do your piece of work with them then. So that has, I suppose, that has shifted as well, I find, in the last year. People, you know, if they find that they're stuck with cases now, they're certainly wondering, is there a communication piece to this? And I think that's what the parents were maybe looking at, what was going on at home with different eyes now, questioning, is there a communication piece to this, and how can we support communication, particularly at times of distress? Great. So I'd be happy to share that as well, Jennifer.
Yeah, that'd be fantastic.
Yeah. There's no more questions, and I have to go to another session, so people are, we could probably talk about this all day.
I know, it was great. Yeah. And look, as I said, I wouldn't, you know, I'm sure you look at our stuff and you'll think, well, there's other ideas or other ways we can add to it. And I'd really welcome that kind of feedback as well. It'd be great.
Yeah. Well, it was excellent. And I certainly inspired to read up and get some references. I'd love to see the CAMHS made simple in our clinic as well. So many people just rock up and really they haven't looked at the website. I mean, we have it on our website, but maybe there's so much anxiety in coming. The booklet is much more accessible.
Absolutely.
Sure, we could share with you the template if you want to redesign it with local Lucina logos or whatever. I'm sure myself and Shifa could send that on to you.
You'd certainly be acknowledged. But that would be brilliant. Thank you.
Sorry, I know you have to go, Ger, but just to say congratulations to Marie and Shifa and Jennifer. I really enjoyed all the presentations. Obviously great work going on in your services as well. So it's great to have the opportunity to hear all about it this afternoon.
Okay.
Thanks
Thank you so much.
Well
done, everyone. And my dog didn't bark, which is it all worked out. Thank you. Bye.
Okay, bye everyone.
Happy Friday.